Welcome to the lecture on the assessment and treatment of rheumatoid arthritis, inflammatory spinal disease from the chapter of the same name. This chapter is written by Bronick M. Postchick, spinal surgeon, Adrian C. Jones, rheumatologist, and is narrated by myself, Adrian Jones. The objectives of this talk, and to emphasize the areas within the chapter, is to talk a little bit about what rheumatoid arthritis is as a paradigm of an inflammatory spinal condition. I'll talk a little bit about the epidemiology of rheumatoid arthritis and the pattern of spinal involvement. We'll talk about the pathophysiology of the disease and how it causes instability and damage within the spinal cord. And I will talk a bit about the wider clinical features of rheumatoid. Finally, we'll talk about the management of rheumatoid arthritis, both to give an update on the current modern management of rheumatoid and to consider some of the relevant surgical considerations. More detail on types of surgical technique will be covered in other chapters. When talking about any inflammatory joint disease, I think it's important to talk about the four domains. Rheumatoid arthritis, like all inflammatory joint diseases, is not just a disease of the joint. There is a systemic component, which can be very severe in many cases. One needs to think about treatment effects, both positive and negative. And finally, rheumatoid and other inflammatory diseases are often associated with significant comorbidities, and in particular, features of the metabolic syndrome. So how do we define rheumatoid arthritis in the current day? The European League Against Rheumatism and the American College of Rheumatology have come up with joint classification criteria for rheumatoid arthritis, which is internationally agreed and published in the Annals of Rheumatic Disease and the Arthritis and Rheumatism journals in 2010. There are two ways of classifying rheumatoid arthritis. The more complex way, and I find less useful for clinical practice, is the classification tree. I think more useful to practicing clinicians is a simple tabulated score. Essentially, a score of more than 6 out of 10 in an appropriate patient with a possible inflammatory arthritis is used to classify rheumatoid arthritis. There are four components that make up this score. The first is the pattern of joint involvement. Essentially, the more joints that are involved, and particularly if these are small joints, such as those of the hands and the feet, the more likely this is to be rheumatoid arthritis, as opposed to one of the other inflammatory joint conditions, such as psoriatic arthritis or the seronegative spondyloarthropathies. Secondly, serology is used. Traditionally, rheumatoid factor has been a major autoimmune test for rheumatoid arthritis, but it has relatively low specificity as it increases with age and in a number of other medical conditions such as chronic infection. More recently, the use of antibodies directed against citrulline-native proteins have become popular. These are variously known as anti-citrulline-native protein antibodies or anti-CCP or cyclic citrulline-native protein antibodies. In the classification criteria, they're termed ACPARs, and essentially a positive rheumatoid factor or ACPAR or both increases the likelihood of rheumatoid arthritis. And as you can see on this slide, having both adds 3 to the score, having neither adds 0. We also want to look at acute phase reactants. It is true that patients with small joint involvement, particularly of only a few joints, may not have an acute phase response, but essentially the presence of an elevated CRP or ESR is much more likely to indicate a persistent inflammatory arthritis such as rheumatoid. And finally, because of the drive to try and see people at an earlier stage and instigate earlier treatment, as we'll see later, has become important, duration of symptoms is an important differentiator between those patients who might have a transient self-limiting arthropathy and those who will have more persistent disease. The diagnosis of the seronegative spondyloarthropathies has also become somewhat simpler. And for example, using ankylosing spondylitis as an example, it now only requires sacroiliitis on imaging, and this can now be MRI as opposed to radiological abnormality, plus one clinical feature, or in some cases an HLA-B27 positive result and 2 clinical features. The clinical features are worth noting, as these are the features that are found in patients and their families in this group of conditions, which are linked by these tendencies to develop things such as uveitis, psoriasis and Crohn's disease. I think a particular note when we're talking about inflammatory back pain or arthritis, we're talking about morning stiffness and inflammation, which, to be precise, is after a period of inactivity and when the patient starts to move, they feel stiff and encumbered, and last more than about 30 minutes. In particular, I'd like to point out dactylitis, since this is almost pathognomic of this group of conditions, and this is the clinical sign of a sausage digit, often a toe, and again, if this is not sought by specific inquiry and examination, it can often be missed. So, using these definitions, looking at the epidemiology of rheumatoid arthritis, what do we know? We know that it's relatively common. It affects approximately 1% of the adult post-pubertal population. It's more common in women than men. For reasons that aren't entirely clear, it's reducing in severity and prevalence. There's a bimodal peak of onset. Traditionally, we've been taught that rheumatoid arthritis is a disease of fertile women, which undoubtedly it is, but it's becoming increasingly recognized that onset in the elderly is not uncommon and requires just as active an approach to management as onset in younger people. It is often triggered by stressful life events. This is not to say that these events cause rheumatoid arthritis, simply that the onset of arthritis is likely after a period of stress or indeed in the postpartum period. High parity is also linked with rheumatoid, and it's thought that sex hormones, in particular those related to lactation and pregnancy, may be an important factor. Socioeconomic disadvantage is a risk factor for rheumatoid and also for poor outcome, and clearly that can be a challenge in many health communities. Rheumatoid arthritis is probably linked to the metabolic syndrome, and diabetes mellitus is a common accompaniment. And finally, and perhaps very importantly for surgeons, smoking is linked to the prevalence and, more importantly, the severity of rheumatoid arthritis and a number of other inflammatory joint diseases. Genetics has long been recognized as a risk factor in a number of inflammatory joint diseases. To look at two examples here, rheumatoid arthritis has had a long-established risk related to genetic HLA types, but we know a number of other genetic loci are also important in the development of rheumatoid arthritis. Notwithstanding this, the heritability of rheumatoid is actually surprisingly low, and indeed in concordant twins, concordance for rheumatoid is actually perhaps less than 20%. In ankylosing spondylitis and the other seronegative spondyloarthropathies, again, there's been a long-established genetic risk, as evidenced by its commonality of the seronegative arthropathies in number of family members. This seems to be more linked to HLA class 1, such as B27, but other risk factors are now well established. The heritability of the seronegative spondyloarthritis, in contrast to rheumatoid, is high. And a family history should be sought, not just of ankylosing spondylitis itself, but for one of the other aforementioned associated diseases such as psoriasis, uveitis, and inflammatory bowel disease. So on to spinal involvement in rheumatoid. This is relatively common. If one uses CT scanning, maybe as many as 41% of established rheumatoid patients will have some evidence of craniocervical involvement, and on MRI this figure is even higher. In longitudinal studies, cervical spine involvement can occur early, and certainly maybe as many as 80% of patients will develop cervical spine involvement within 20 years. This, of course, is data derived from historical cohorts, and the outcome now may be improved, as we'll discuss later. Of the 80% who have craniocervical involvement, perhaps only 5% will develop atlantoaxial instability, and of these, perhaps only a further 5% will develop neurological impairment. So why do we get rheumatoid arthritis affecting the spine? Well, rheumatoid does affect specific target sites and may affect a number of specific antigens, which include many proteins such as collagen and aggregan and lig protein, which are involved in the structural integrity of ligaments, particularly in regions where there's mechanical loading or ligaments are drawn across osseous prominences. Perhaps the best example of this would be the transverse ligament in the cervical spine, which is a particular target site for rheumatoid arthritis. Not only is there damage to the proteins, there's also the formation of pannus. Pannus is an inflammatory mass of altered synovium with a large lymphocyte infiltration, which can behave in a locally aggressive manner. This can typically erode into the odontoid process itself, soften the transverse ligament, or even erode into the C1 lateral masses. This MRI, courtesy of Professor Qureshi at Nottingham University Hospital, clearly shows pannus behind the odontoid with a compressive element onto the spinal cord. There's also pannus extending anterior to the odontoid, although there's no significant erosion as yet. So what about the clinical features? Well, this depends on the disease, and in the next couple of tables we'll show you ways of distinguishing between the various types of arthropathies, both rheumatoid, seronegative spondyloarthropathy, but also the crystal diseases and juvenile inflammatory arthritis. It's important to look at some of these clinical manifestations in family members, particularly in those with seronegative spondyloarthropathy. The symptoms and signs and history may be historical, as in the patient may have had uveitis many years before presenting into a spinal or orthopedic clinic, and of course they may not be volunteered, as patients may not necessarily appreciate the link between, for example, their eye disease and their spine disease. The first table shows a number of the features of these four conditions. Rheumatoid is a symmetrical polyarthritis, often affecting the small joints. Clearly, it does affect larger joints such as ankles, shoulders, knees and elbows, but nearly all patients with rheumatoid have small joint involvement. This tends to be symmetrical, not in severity, but in distribution. The seronegative spondyloarthropathies tend to be more of a polyarthritis or oligoarthritis, and as discussed before, may be associated with dactylitis. They are often asymmetric. Juvenile idiopathic arthritis, as it's now known, has several subtypes defined by the pattern and number of joints involved within the first 6 months. Spinal involvement is not uncommon, and because of the age of the patients affected, can lead to growth abnormalities. And finally, crystal synovitis may complicate osteoarthritis and lumbar and cervical spondylosis, and may be evidenced by chondrocalcinosis on radiographs. The eye manifestations are also shown on this slide, and in particular I would think of rheumatoid disease as being a disease of the sclera, dryness, episcleritis, whereas the seronegative spondyloarthropathies are associated with anterior uveitis or iritis, a dusky red painful condition. In the skin, seronegative spondyloarthropathies are associated particularly with acne and psoriasis, and although a number of names are given to forms of skin disease associated with seronegative arthritis, such as keratoderma blennorrhagica, essentially these are all forms of psoriasis. Rheumatoid skin involvement is usually just rheumatoid nodulosis, but in patients with severe advanced disease, they may develop vasculitis with subsequent ulceration. Dryness, which in surgical terms may be important because of eye damage or oral hygiene issues, is common in rheumatoid and the connective tissue diseases. And all these conditions are associated with osteoporosis, which clearly is of importance to the surgeon who's contemplating surgical intervention. A number of these conditions, particularly in rheumatoid, are associated with lung involvement, and again, this is more common in patients who smoke. All patients are troubled by GI tract involvement related to drugs such as non-steroidal anti-inflammatory drugs, but in particular those with seronegative spondyloarthropathy may have increased bowel permeability and associated inflammatory bowel disease. The final point I would like to make is that all these conditions are associated with ischemic heart disease. This obviously is aggravated by smoking, but it does seem a common component of all patients who have inflammatory diseases, particularly inflammatory arthropathies. And an increased cardiovascular mortality is to be expected and must be taken into account when considering surgical intervention. To mention the seronegative spondyloarthropathies, I've shown you a number of related conditions which all can be associated with spondylitis. Reactive arthritis is an inflammatory arthritis triggered by infections, the commonest of which in the UK is probably Campylobacter, but it's also associated with chlamydia, which may be direct septic arthritis. Synovitis, acne, pustulosis, hyperostosis, and osteitis may be of interest to the spinal surgeon and neurosurgeon because of the association with chronic recurrent multifocal osteomyelitis, an apparently sterile form of inflammation. Spine involvement in a rheumatoid can occur anywhere in the spine, but it's usually only clinically relevant in the atlantoaxial region and the upper cervical spine. The reason for this is not clear. Post-mortem studies do often show rheumatoid involvement in many tissues in the body, but it is probably the presence of marked pannus in the cervical region where compression can become an issue very quickly. That means that it becomes clinically apparent. The clinical features of this spine involvement include neck pain, particularly in the craniocervical junction, and associated occipital headache, paresthesia, numbness from pressure on the occipital nerve. Occasionally, ear or mastoid pain may be a presenting feature, and patients may be conscious of crepitation or a sensation that the head feels unstable and falling forward on flexion. Very occasionally, a palpable clunking can be felt when examining a patient with rheumatoid involvement of the neck, and this is always quite distressing as a clinician. Of course, the most important feature is the signs and symptoms of myelopathy. Clearly, one can get radiculopathy with rheumatoid involvement, but it's the myelopathy that causes the greatest concern and can be difficult to examine for in the presence of substantial joint damage. So how do we assess patients with rheumatoid? Well, clearly we have a number of clinical assessments that use validated disease outcome measures. These are mostly used in some healthcare systems to determine eligibility for biologic treatments, which are our more advanced treatments. But they're also an important way of monitoring patients to see whether we are treating to target, which is the current paradigm for treating people with inflammatory joint disease. We use a number of inflammatory markers, probably the most important of which is C-reactive protein. There are a number of diagnostic tests, including autoantibodies, and as is most relevant to this talk, imaging. Imaging can use a variety of techniques. Plain radiographs are easily available, but lack sensitivity, and by and large tend to be two-dimensional, restricting some of their use. They are easier to perform with a degree of loading and with a degree of motion such that instability may be apparent. CT scanning, like plain radiography, can be useful for demonstrating bones and bony alignment, but ultrasound, particularly with power Doppler, and MRI are much better at showing soft tissues, neural tissues, and a degree of inflammation and so-called disease activity. This is the traditional atlantoaxial instability assessment using plain radiographs. One can see on the picture on the left that in extension, the odontoid is relatively closely applied to the atlas, but on forward flexion, the distance between the odontoid and the axis, as demonstrated by the double-ended arrow, increases. This has traditionally been used as the measure to assess atlantoaxial instability, but really what matters is the posterior distance between the dens and the posterior arch of the atlas, because that is the space within which the spinal cord is traversing. Probably a distance of less than 13 millimeters is likely to indicate the risk of neural compression and the need for intervention. Subaxial instability can also be appreciated on these views and is not uncommon. A number of measuring techniques have been advocated for use in assessing atlantoaxial instability, particularly with plain radiographs, but these have largely been supplanted by MRI. On MRI, the most practical assessment is that for basilar invagination. The difficulty of measuring instability in terms of just anterior-posterior translation is that when there is significant joint damage and loss of the lateral masses, there can be basilar invagination of the cervical cord and brainstem due to encroachment of the odontoid. This is much better appreciated on MRI, and we would advocate that all patients in whom rheumatoid neck involvement is considered important should be assessed with MRI. As you can see on this scan, there's a large mass of inflammatory tissue around the odontoid, as evidenced by the high signal, but also demonstrating erosion into the odontoid peg, which will lead to instability and difficulties with fixation. When you look at the spinal cord on this image, you can see that there is high signal within the spinal cord suggestive of repeat impaction due to instability and movement and probable myelinosis. This scan demonstrates Wackenheim's line, which is drawn from across the clivus, and as you can see, the odontoid extends superiorly beyond that line and is invaginating the brainstem. So on to modern medical treatment. What do I as a rheumatologist aim for? Well, the aim is to aim for complete suppression of disease activity. This involves seeing patients early and advising drug treatment, which is largely immunosuppressive, early on. In the UK, the target is to see patients with suspected inflammatory arthritis within 3 weeks and to have them on treatment within 6 weeks of symptom onset. Clearly, this is difficult, and often many patients are in a diagnostic timescale when the pattern of disease has not become established and tests may be inconclusive. At this stage, we would use early imaging, particularly with ultrasound, to try and make the diagnosis at the earliest possible stage. We would use rapid step-up combination therapy with traditional disease-modifying anti-rheumatic drugs, or DMARDs. These would include methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. They will also tend to be used with corticosteroid bridging therapy. There are concerns about long-term corticosteroid use in inflammatory joint disease, so one would try and use them for maybe the first 3 months while we're achieving benefit with the more traditional agents. Amongst the DMARDs, methotrexate is considered an anchor drug in rheumatoid arthritis with a number of benefits, including possible reduction in cardiovascular risk. Increasingly in most healthcare systems, early change to biologic therapy is used if traditional drugs are unsuccessful. From a practical point of view, all patients admitted under surgery should be with rheumatoid arthritis or other inflammatory joint disease should be expected to be on potent immunosuppressive therapy unless you have good reason to suspect not. This is particularly important in the emergency situation. What do we do about these drugs during surgery? There's limited data for this, but there are a number of principles that perhaps should be considered. Firstly, active inflammatory disease, and in particular rheumatoid, is a potent immunosuppressant in and of itself. So when possible, particularly in elective surgery, one should be aiming to have patients with low or disease activity with a normal CRP preoperatively. Drugs to try and achieve that are probably themselves more helpful than letting patients flare. Corticosteroids, however, are associated with perioperative complications and should be minimized before surgery. And in this situation, there's a real tension between reducing the immunosuppression burden and letting the disease flare and having to rescue with corticosteroids and carrying on drugs. What we do think is that methotrexate is associated with reduced perioperative complications, and the feeling is that in most instances this should be continued perioperatively. Clearly, if patients are ill by mouth or develop acute renal failure, this may need to be reconsidered. All the biologic therapies are probably associated with increased perioperative complications and should be avoided in the immediate preoperative period where possible. Different healthcare systems have different advice for how long before, but generally speaking, 2 doses before, or in the case of rituximab, which is given every 6 to 9 months, surgery should probably be delayed until perhaps 2 months after the last rituximab infusion. Rituximab can also be associated with hypergammaglobulinemia, and again, this gamma globulin should be checked prior to any surgery. In the perioperative and preoperative assessment of all these patients, a number of things should be checked. I've already mentioned that cardiovascular risk is increased in people with inflammatory arthritis, and it would be prudent to make sure they're as cardiovascularly healthy as possible with relevant ECG, echocardiography as required. In all patients, there should be a full blood count, checking particularly for neutrophils, platelets and hemoglobin. Renal function should be assessed, as well as liver function, as a number of our drugs are both nephro and hepatotoxic. So what is the indication for surgery? Well, one of the things that has been a success story of our new treatments is that the need for surgical intervention has decreased with time. And actually now, as a rheumatologist of some 25 years standing, referral of patients for consideration of spinal surgery is now very uncommon compared to when I first started in practice. It's not clear whether this is part of the secular trend of rheumatoid or is related to better drug therapy. However, some patients still come to harm, and we need to try and intervene at a stage when the situation is salvageable. So we would certainly consider surgical intervention for those with progressive neurological compromise and those with pain. Personally, I think it's unhelpful to screen for atlantoaxial instability and intervene on patients who are otherwise well, as the risks in this situation probably outweigh any potential benefit. However, it's important not to wait too long. After patients have developed objective myelopathic deficits, they are likely to be bedridden within 3 years and have a 5-year survival rate of less than 50%. In similar patients with myelopathic deficits who are operated on, then you would expect maybe a 60% neurological improvement and an 80% 5-year survival rate. Clearly, selection bias may be in play here, as many patients with progressive myelopathy tend to be patients who are frailer and have multiple comorbidities or complications from their rheumatoid and may not themselves be eligible for surgery. Once patients have become non-ambulatory for more than 3 months, it's very unclear whether surgery has a useful role to play, and recovery of ambulation is likely not to occur. What are the surgical interventions that can be offered? Well, this will be discussed further in other chapters, but essentially non-operative interventions as a rheumatologist I don't feel are very helpful. Cervical collars are thought largely to be ineffective and indeed may make things worse. And halo stabilization devices, although these stabilize the spine and may induce regression of the pannus, are associated with quite significant morbidity, particularly in frailer patients with poor skin conditioning and a risk of falling. And as a rheumatologist, I'm always very wary of suggesting this in patients who might benefit from more interventional surgery. The type of intervention is driven by the underlying pathophysiology, comorbidities and neurological complication, but often in situ stabilization is effective. And interestingly, reduction of movement may cause reduction of the post-odontoid pannus. As I say, surgical techniques will be discussed further. So, a few take-home message. Rheumatoid disease is a severe multi-system disease that needs active intervention. As a surgeon, this is not a simple joint disease. These patients are ill and have an increased risk of morbidity and mortality. Smoking is a modifiable risk factor in inflammatory disease, and patients should be counselled regarding this. You should assume that all patients are receiving immunosuppression, particularly in the emergency situation where notes and records may not be available. Be cautious about surgical intervention in non-symptomatic patients, but myelopathy is a harbinger of deterioration and intervention should be considered. Close liaison between a surgeon and the patient's other physicians, including the rheumatologist, is, in my opinion, essential.